Okay. Uh, Good to go, Heta ma'am. Should I start?
Just a minute. Good morning, everyone. I'm Dr. Heta Patel from IAP Digital Media Team. I'll be hosting today's webinar, which is on Beyond the Kegel, what every physio should know, with resource person Dr. Rhythm being organized by IAPWC Rajkot team. The Indian Association of Physiotherapists is the oldest and large association representing physiotherapists in India since 1955. The IAP digital media team consists of a group of physios who handle the Zoom platform, webinar live streaming, and IAP profile on social media platforms Facebook, Instagram, Twitter, LinkedIn, YouTube. Follow the IAP profile on this social media to receive a notification for our events such as webinar, workshops, CMEs, conferences, health camps, blood donation drive, and to know about recent updates on physiotherapy. Subscribe to IAP YouTube channel for notification for our live webinars. In the playlist section of this channel, webinars are segregated into various folders on topics like orthopedics, neurology, sports and fitness, pediatric, cardiopulmonary, women's health, research, cancer rehab, and many more for easy access. The social media link will be shared in the chat shortly, and the question answer session will be at the end. So I would like to invite Dr. Vaibhavi Ved and to handle the next part. Ma'am, over to you.
Thank you, Heta ma'am. Good morning, everyone. A warm welcome to all our participants on this Sunday morning. Let me share with you today a quote I truly believe in as a clinician. Uh, your eyes only sees what your brain knows, meaning you will only be able to see those symptoms, those problems, or differentially diagnose those conditions if you are aware or you have learned of it. And thus, our need of learning never ends. To enhance and elevate this clinical practice, let us begin today with our session Beyond Kegel's What Every Physio Should Know. Let me introduce to you all our expert for today's session, Dr. Ridham Sampat. Dr. Ridham Sampat is an internationally trained physical therapist with over a decade of experience spanning Singapore and the United States. After graduating in 2011, she has practiced in Singapore for 9 years across community hospitals and outpatient clinics, building a strong orthopedic and rehabilitation foundation. In 2021, she moved to US and advanced her specialization in pelvic floor rehabilitation. She has completed advanced pelvic health training through the American Physical Therapy Association, APTA, and the Herman and Wallace Pelvic Rehabilitation Institute. She is also certified in dry needling, pregnancy and postpartum corrective exercises, and orthopedic manual therapy, and holds an active license in New York and Pennsylvania. Today, she treats pelvic floor patients in both hospitals and private clinical setups, blending orthopedic reasoning with pelvic health principles to deliver comprehensive functional care. Through her platform, Pelvic Health Academy, she is committed to transforming pelvic health education for physiotherapists globally by integrating evidence based science with practical clinical application. And above everything, she's a very good friend of mine since years. So before handing over to her, I would like to give you all few guidelines. We are all going to have around a 45 minutes of session hereafter, and all of your participants are on a mute mode to avoid disturbances and maintain the decorum of the session. But we would request you that in case of any query, you can type into chat box and we will get back to those queries and address those queries at the end of the session. Okay, then let's begin for today's journey. Over to Dr. Rhythm.
Yeah. Thank you so much. Thank you so much, Vibhurit, for introducing me. Yeah, and I am so happy to be here today. in order to celebrate the Women's Day. And yeah, I would like to really deeply share my gratitude towards the Indian Association of Physical Therapy, the Women's Cell, for organizing this thing and to getting the whole physical therapy field together so that we can advance our knowledge more in the academic field and more in the practical field. Thank you so much. I'm looking forward to today's session. I hope that everyone gets to know a little bit more about the pelvic floor and we are able to gain at least 5 things that you could start practicing from Monday morning when you go to your practice and you are able to change a bit of it and you're able to include the pelvic floor while you are screening for patients or while you're treating for patients. Yeah. Uh, I am going to share my screen so that we can start. Are you able to see my screen?
Yes.
Perfect. Okay. So yeah, this is, of course, like as we mentioned, I am working as a physical therapist for past more than a decade. And this is me with my lovely family. I have 2 kids. So outside that, I have like 2 kids with my husband and my parents. And I am a proud mother to all of them. And I have completed my training and I have completed my training for physical therapy in like pelvic floor with Herman and Wallens and APTA. And just now I practice in a hospital-based system that's called Mainline Health, where I see my patients there and in a private clinic. And I look forward to today's session. I hope you all would enjoy this. The learning objectives for today is going to be, just give me a minute. Why is this not working? Yep. Today we are going to explore like why pelvic health is just not a niche and why it's not just that only the people who are trained or certified in pelvic floor should only be screening for it. Everybody, as a therapist, we deal with patients day in and day out. And like I want to make sure that we are getting into the deep understanding of it and why it's like to recognize why it's not just a niche. And then the second objective is to assess breathing, intra-abdominal pressure, and core coordination during the functional task, um, and to guide the pelvic floor interventions. The third objective is to describe the 3 layers of female pelvic floor. The fourth one is to identify the common clinical mistakes. And the fifth one is to apply actionable, like Monday morning strategies that I hope that you guys would be able to take away from this. Okay, now let's look into why pelvic floor dysfunction is not a niche. Okay, look, as a physical therapist, we all have been taught about the axial, like the shoulders, the hip, and the spine, but we are not taught in detail about the pelvic floor. Like whenever these muscles we are not able to see very easily, we are not able to touch those muscles very easily from outside. And that's the main reason why people are not able to like talk about it, or they don't have as much awareness as it should be. But that does not mean that these muscles, they do not affect our quality of life. Right? Pelvic floor muscles, they are anticipatory muscles. Like they are the muscles that are going to first kick in when we change any of our positions. Like even if while we are sitting, and from sitting when we are trying to even get up from the chair, or we start walking, or we start running, anything happens, those are the muscles that would kick in first. In many cases, we may also be clenching or we could be tightening those muscles unnecessarily. That is like any other muscles, right, in the body. And these muscles, they also need to learn how to uh, how to coordinate, how to relax, and how to be strengthened. And as PTs, like we have been seeing the cases of low back pain, hip pain, SI joint pain, right? Day in and day out. Now let's try and connect and understand how these muscles, like our low back, hip, and SI joint, and the abdominal muscles, are connected to our pelvic floor. And let's understand how they all can work together. We can think about our abdomen as a pressure chamber. Okay. Now it must manage the pressure. The abdomen must manage the pressure during all the tasks, such as lifting, coughing, sneezing, or even laughing. And if one part of the system fails or the system like leaks, then the whole of the system gets affected. For the abdomen, the roof is made with the diaphragm, the floor is made with the pelvic floor, the front is with the transverse abdominis, and the back is the multifidus. Okay. All this, all the four of it together forms the core. It's not just our abdomen. And all of them need to work in sync with each other. For example, imagine that a person with recurrent low back pain due to mechanical issues, they might have either tight paraspinals or they would have weak abdominal. And let's see how this could affect the pelvic floor. Now, if a person with recurrent low back pain comes in, they could have either of two. It could be that they have an overactive or a tight pelvic floor. And when this happens, like when the lumbar paraspinals and the back muscles, they are constantly guarding the pelvic floor, may also stay in a protective and an overactive state. And this could lead to pelvic floor tightness or pain in the pelvic region. It could lead to dyspareunia. There could be difficulty relaxing during the bowel movement, which could lead to constipation or incomplete bladder emptying. And if because of the mechanical back pain, and if the person has some other like conditions such as pregnancy or maybe postpartum, there could be weakness or it could be poorly coordinated pelvic floor. And if the pressure management is poor due to weakness, the intra-abdominal pressure, it pushes downwards without proper support from the pelvic floor. And this could contribute to urinary incontinence, pelvic organ prolapse, or feeling the heaviness in the pelvic area. Or it could be like poor pelvic floor timing with movement. So the takeaway from this is like we have to start thinking of core as a whole system and not just our abs or not just like we could start thinking about the whole abdomen as a system and not just as only back or as the abs. And pelvic floor does not function in isolation, and neither does our back muscles or neither does our abdominal muscles, right? So when any one of the system, it either underperforms or it has any kind of dysfunction, the other systems are always like the one that also compensates with it. Another way of thinking about the whole core is we can think that the whole of the core is like a soda can. And whenever, okay, if we imagine the whole of the core like a soda can, we have to imagine like there is a sealed soda can, and the top of the can is the diaphragm. The bottom of the can is the pelvic floor, and the sides are the abdominal wall and the deep muscles. Okay. Now, when the can is intact and the pressure is like properly stable and strong, it is all good. But if one of the wall is either weak or dissociated, the whole structure, it becomes like unstable. So during inhale, the diaphragm has to contract and it moves down and it increases the pressure gently on like the top of the can. Now the pressure is built inside and the pressure inside increases. The important part is that the pressure should be expanding in all the directions and not just downwards. The abdominal wall, it has to expand like 360 degrees. The pelvic floor has to respond by lengthening, and it should not be clenching at that point in time. So this has to be a responsive system. And this has to be also controlled by pressurization, and it should not be a very forceful brace. So during inhalation, we expect that the diaphragm would be expanding 360 degree. We are going to get a bit of lengthening in the pelvic floor. And during exhalation, for example, like whenever there is an exhalation, it has to be, of course, a passive movement. But during that, the diaphragm has to relax and raise up. And when the diaphragm relaxes and raises up, the pelvic floor also has to mimic the diaphragm, and it has to also come back up. And the transverse abdominis, it has to also contractively and reflexively come back to its position, and it has to also relax. And all of this has to happen in coordination. And this creates like controlled stiffness in the soda can. Now imagine that one of this system has dysfunction. For example, the pelvic floor has dysfunction, okay? And there is an increase in the pressure. And we are not exhaling at that point in time. So the pressure is increasing in the soda can. And the pressure would find the most weakest point in that, and it would come out. So whenever we are inhaling and we are holding the breath while we are trying to do any kind of strenuous activity, that pressure goes onto the pelvic floor and that leads to dysfunction. So how can we avoid this? Is we have to always teach our patients that you have to exhale as you go, which means if we are popping on the top of the soda can, we are exhaling during the exertional part, then that pressure gets released and it is not being pushed onto the pelvic floor. And that's how we can protect the pelvic floor. Let's look this into more detail. For example, if I talk about a simple activity that we always give to our patients, which is sit to stand. Okay, now I want you to look at this simple exercise through a pressure point of view. Okay. It is during the inhalation, like for example, if a patient is sitting, everything has to be well aligned. The rib cage has to be stacked over the pelvis. The feet has to be on the ground. The pelvis has to be neutral. Now we have to always cue that you have to inhale before the movement. So what should happen physiologically is the patient is sitting, the patient is inhaling. So the diaphragm contracts, it pushes, the diaphragm contracts and comes down. The intra-abdominal pressure, it increases, and the abdominal wall, it has to expand 360 degree, and the pelvic floor lengthens. Now this creates like expandable pressurized cylinder. This is not rigid and this is not braced, okay? Now during the standing up phase, which is the exertional phase, as the patient leans forward and begins to stand up, we ask them to exhale. So when they exhale, what happens is the diaphragm relaxes, it goes back to its position. The TA, transverse abdominis, it gets activated. The pelvic floor, it also co-contracts reflexively. and the glutes fire and the spine stabilizes. This way, the pressure is directed upwards and outwards and not down onto the pelvic floor. And this whole strategy would lead to an efficient load transfer. So the thing that we can take away is, like, instead of cueing whenever we are doing any of this kind of exercise, like instead of saying just like engage your core or pull the belly button in, we could say take a breath in and feel your ribs expand. Or we could say now gently exhale as you are standing, and we let the pelvic floor respond and not squeeze. The pelvic floor, it is an anticipatory muscle, so it has to kick in itself instead of us cueing it all the time. That is a big difference. Like, if you can teach that to the patient that, oh, this is an anticipatory muscle, you have to feel how the muscle reacts when you are doing a particular activity. That would help the patient create that neuromuscular connection with their pelvic floor. And that one breath, while we are working on the breath and while we are working on the exercise, can reduce the lumbar compression. It could improve the glute firing time. It could reduce the pelvic floor overactivity, and it can also decrease the symptoms. Okay. And all the corrective exercises, right? This strategy is not just meant for sit to stand, but we can translate this strategy to all the exercises that we might be giving to the patient as a physical therapist, such as like any of the leg exercise or core exercise. All the exercises, they are like coordinated pressure events. So if a patient is able to manage the pressure properly, we could get them to have less of the pelvic floor dysfunction. And by having that strategy in place, like blow as you go, they are able to manage the activities of daily living, such as lifting, running, or carrying a toddler in a much safer way. It is mostly when the person is not able to manage their pressure correctly that leads to the dysfunction. So it's very important for us as therapists to understand how to get them to manage that. So always remember, never ask the patient to hold their breath, and we have to encourage them to always exhale at the hardest part. And when they are exhaling, also for them to connect to their pelvic floor and to see if the pelvic floor is being lifted as we exhale. And that way it is going to provide the support that is needed for the whole core system. And let's look into why does this whole thing matter? Like, why does it matter for us to screen for this? Or why does it matter for us to talk about the pressure? And why is it important to exhale when we are getting into the exertional part? Most of the time, like whenever we see our patient and we ask them like to get up from their chair or ask them to do any kind of exercise, I want us to notice that how is their chest breathing? Is there enough air going into the chest? Is there any kind of rib flare? Are they doing any kind of abdominal gripping? Are they doing butt clenching before the movement? Is there breath holding? Is there any audible strain that they're having before getting up? Is there any delayed in glute activation? And if you're able to identify any of this dysfunction, I think now we are able to connect the dot. Oh, because they are also having all these dysfunctions, they might also be experiencing some kind of pelvic floor dysfunction. And if you're able to feel that, oh, this person might also be having pelvic floor dysfunction, you could ask them a few questions, a few screening questions that might lead to that information. These screening questions are very easy to incorporate into our daily MSK or any kind of daily examination that we do. I have taken this up from a questionnaire called Cousin's Pelvic Dysfunction Screening Questionnaire. Cousin, she is a physical therapist here in the States. She has come up with this questionnaire, and the interpretation is if the patient answers 3 yes out of this 10 questions, the patient would have pelvic floor dysfunction, and the patient would always benefit from seeing a pelvic floor therapist who specializes in doing an internal work with the patient. But it is always good for us as therapists, even though we might not be specialized for pelvic floor, but as a ortho clinician or even as a neuroclinician, to go through this screening questionnaires with the patient so that we are able to increase our care for them. The first question is that, do you have any pelvic pain, any pain that you have experienced and that exceeds, say, 3 out of that exceeds 3 out of 10 on the pain scale? And then you can ask them, do you remember falling onto the tailbone or the lower back or the buttocks? This could even be in childhood, which might also lead to pelvic floor dysfunction. The third questionnaire, the third question that we could include in the questionnaire is, do you sometimes experience urinary symptom, such as accidental urinary leakage, or the feeling that you are unable to completely empty the bladder, or needing to void again within few minutes, or burning or pain with urination, or difficulty starting or stopping the urine flow? The fourth is, do you often or occasionally wake up at night to urinate twice or more than 2 times? And the fifth is, do you sometimes feel pelvic pressure or sensations that the organs are falling or slipping down? The sixth question is, do you have a history of low back, hip, groin, or tailbone pain or sciatica? Seventh is, do you sometimes experience bowel symptoms such as loss of bowel control, incomplete bowel emptying, strain, or pain with bowel movements, and difficulty to starting a bowel movement? The eighth is, do you sometimes experience pain or discomfort during sexual activity? Ninth is, does sexual activity increase any of the symptom? And the 10th is, does prolonged sitting increase any of the symptom? So after asking all this, if the patient says yes to more than 3, that is the sign that, okay, this person might have pelvic floor dysfunction, and the person might be benefited with seeing a pelvic floor therapist. But even before you refer them out to the pelvic floor therapist, you as a physical therapist can help them with the pressure management. You can help them guide to get the 360-degree breathing to relax their pelvic floor. And pelvic health is not just about gynecology, it's all about coordination, and it's about pressure management, load transfer. And every physiotherapist, as a physiotherapist, we always treat the pressure and the load. And if the pelvic health is influencing so many systems, we should also understand what pelvic floor actually does. And it's not just like the strength, but how does pelvic floor also relax and how does it coordinate? To understand that better, I am going to walk us through all the layers of the pelvic floor. So this is our pelvis. Now think of the pelvic floor is made out of 14 muscles, and those muscles have both slow twitch and fast twitch fibers. And these 14 muscles, they form like a hammock. Okay. They expand from the pubic symphysis to the sit bones, and they go to the tailbone. Let's look, they are made out of 3 layers. Let's look at each layer individually and let's see how and what is the function of each layer. So the first layer is the superficial layer. This layer has 4 muscles. Are you able to see this? Let's see. Okay. So this is the first layer. This is the superficial layer. The superficial layer has 4 main muscles. The first one is the bulbocavernous. The second one is the ischio-cavernous. The third is the superficial transverse perineal. And the fourth is the external anal sphincter. Now, these muscles, they are heavily involved in the sexual function and for closure of all the 3 openings. These are the muscles, especially the bulbocavernous, the superficial perineal, STP, superficial transverse perineal, and the external anal sphincter. These 3 muscles usually sustain any kind of perineal tears during pregnancy or during delivery. So these muscles are, the superficial muscles are really involved during the delivery or during the tear. And that's why these muscles, they need to learn how to relax during the childbirth. The second layer is once we remove these muscles, we get into the second layer. Okay. The second layer is called the urogenital diaphragm. Now, these muscle, it has the urethral compressor muscle. That is the muscle that helps with the continence of the bladder. The other one is the deep perineal muscle, the deep transverse perineal muscle. These muscles are mainly responsible for urinary continence, and this helps to keep the urethra closed when the pressure increases. For example, whenever we cough, laugh, sneeze, or lift anything, these are the muscles. The muscles of the second layer are the muscles that needs to contract in order to keep the continence. And lastly, we have the third layer, which are the deeper muscles. So these are the deeper muscles of the pelvic floor. This is the pelvic diaphragm. In this, we have the main muscle, which is called levator ani. Levator ani is the group of 3 muscles. Puborectalis, the one that goes around and comes around. Then there is pubococcygeus that wraps around the coccyx, and it wraps around the anal sphincter and the vaginal opening. And there is ileococcygeus that runs behind it. And to the sides are attached is the coccygeus. Then we have obturator internus, and there is this thing called alta. Alta is where it's like a thick fibrous structure that is between the coccygeus and the levator ani muscle. These muscles, they are called the pelvic diaphragm. And this pelvic diaphragm, it mimics the actual diaphragm and it works in coordination with that. And this is like a trampoline or a hammock that supports all the organs. Inside in the pelvic cavity, we have the bladder, the uterus, and the rectum. It also supports all those organs. And this layer is important for the pressure management that we talked earlier. It is also important for the continence. And this layer, it mimics again with the abdominal wall during breathing, lifting, coughing, sneezing. Okay, so these are the function of the pelvic floor. Now, it is, let's look at how should a pelvic floor function in different activities. Usually what happens is, for example, if we talk about a normal muscle like bicep, if we are trying to lift something, it just has to contract, right? But pelvic floor muscles, it's very different. For example, let's talk about what happens and what is the coordination that is required in the pelvic floor during intercourse. Okay, pelvic floor, it's like, it's not just about is it strong, but it's all about how coordinated it is. Okay, during intercourse, the pelvic floor, it must allow the penetration. That means that the vaginal canal, it needs to relax, but the muscles. Okay, so for the vaginal canal, like we need the bulbospongiosus, we need the first layer of the muscles to relax, but the anal muscles, the second layer, the sphincter muscles, they need to contract at the same time so that we have the continence. So that this is where like few muscles need to contract, few muscle needs to relax, and that's the coordination that we need to have for the pelvic floor. And if that is lost, we might have some kind of pelvic floor dysfunction. And that's where the patient would start feeling the pain or guarding or conditions like dyspareunia. And this is why, like, just simply if we come across any patient who has any kind of pelvic pain or any kind of pelvic dysfunction, we cannot just be saying to them, like, okay, Kegels is what we are supposed to do, or just like try and contract your pelvic floor, because at times it's not just about like how are you able to strengthen or just contract. At times, if we just prescribe the Kegels, it could actually make the symptoms worse, and it would require for the patient to learn how to relax and how to coordinate that. The next, let's look into what happens to the pelvic floor muscles during pregnancy and like during childbirth. During pregnancy, like of course, pregnancy is one of the most like profound musculoskeletal changes that the body undergoes. For 9 months, the pelvic floor is just adapting to the increase in the fetal weight. It's adapting to the hormonal changes, the ligament laxity, and the whole change in the intra-abdominal pressure. The levator ani muscle, it actually gradually lengthens, and the pelvis, it widens to accommodate the growing baby. During the vaginal delivery, the pelvic floor muscles, it could stretch up to like say 2.5 to 3 times of its resting length. And we could experience perineal tear, episiotomy, or even like at times we have to go through the cesarean surgery, which is such a major abdominal surgery. And then even after going through such big surgeries, at times the patients are not referred for pelvic floor rehab, or the patients are not referred for any kind of rehab. Now, think about uh, what happens if a person, for example, it's very common that a person goes for total knee replacement and the patient is prescribed, like, you should have pre-rehab and then you are supposed to have a postpartum rehab, right? But if a female, she is undergoing such a big life, like, transitional thing, she is bearing a kid for 9 months, she goes through pregnancy, experiences such major musculoskeletal changes, goes through childbirth, even maybe abdominal surgery, and still she's not routinely referred for rehabilitation, right? So as physiotherapists, we understand, of course, load, we understand tissue healing, coordination, functional recovery. So it's very important that as a pelvic rehabilitation specialist, and as rehabilitation specialist, we can include, sorry, I thought someone was asking a question. Yeah. So yeah, it is very important for us as a rehabilitation expert that we promote more people to get more of care for their pelvic floor postpartum, during pregnancy, during um, any kind of pelvic floor dysfunction. So I want to summarize like 5 big takeaways from today's presentation. The first one is, let's start to add pelvic screening questions to most of the MSK evaluation. I know I gave like about 10 questionnaires. If we are not able to include 10 questionnaires, maybe that time, at least start with 3 quick questions like, do you experience any kind of urinary leakage with coughing, sneezing, exercising? Do you feel pelvic pressure or heaviness? And do you have any kind of pain with intercourse? So all these 3 things, it would mostly ask about all the pelvic floor functions. And if they say yes to this, okay, the person might benefit from talking about the pressure, from talking about how to do 360-degree breathing, how to always tell them to not hold their breath, to ask them to exhale as they go and exhale as they are into any kind of strenuous activity. The second is, I want us to start observing the breathing before prescribing any kind of core exercise. So look for if the patient is having any kind of upper chest breathing, or is there any rib flare? Is there abdominal breathing? If they are holding breath during effort, if they're doing that, teach them 360-degree diaphragmatic breathing. We can tell them, let the ribs expand as you exhale and gently exhale during the effort. Sorry, let the ribs expand as you inhale and gently exhale during the exhalation. And this improves the whole pressure management system and the pelvic floor coordination. The third is, watch the functional task through like through the pressure lens. So any of the movements such as sit-to-stand, squats, lifting, bed mobility, anything, look through the pressure lens. Look, when are they holding breath? Where are they holding breath? If they are, if the pressure is being pushed downwards, if there is any excessive abdominal gripping. And the quick fix again, exhale with effort. The third is, we can start screening for overactive pelvic floor in pain patients. For example, in the questionnaire, if you find that the patient has chronic kind of pelvic pain, or if they are having dyspareunia, which is pain with sex, or they're having any constipation or tailbone pain, these patients, they often have is pelvic floor muscle overactivity. And prescribing like Kegels or just telling them, okay, keep on squeezing the pelvic floor, that would actually do a disservice to them. So especially during that time, chronic pelvic pain, dyspareunia, constipation, tailbone pain, we can give them relaxation, breathing, hip mobility, and pelvic floor down training as a intervention. And of course, always refer early when you see pelvic symptoms, they are present. Of course, as a physical therapist, we cannot treat all the conditions. And if patient reports urinary incontinence, any kind of prolapse, persistent pelvic pain, or postpartum dysfunction, refer them out to a pelvic health physical therapist or physiotherapist. And as a just as a role, it's often about recognition. Whenever a patient is coming to us, and if we're able to recognize that, oh, this patient also has something ongoing, something else going on with the pelvic floor, early referral is always the best. Yep, I'm all done with my presentation. Please let me know if you have any other questions for me.
Thank you so much, Rhythm. Participants, if you have any query, you can please write down in the chat box. Okay. In case due to Sunday morning we have less participants, I would request our speaker to please put down your email address in the chat.
Sure.
So if
Yes, I would
anybody has
definitely do that.
queries or anything regarding the lecture here forth, they can connect you through the email.
Definitely. I am going to put in 2 email address that I am able to be reached out at.
Okay, thank you so much. Thank you so much, our expert Rhythm, for delivering
Thank
such
you.
a wonderful session on Sunday morning. And it was very much insightful for each and every participant and could get us to an extra edge of information regarding our clinical practice, making it more fruitful for the patients. It's not just about women's health or pelvic floor. What I get is it's about an holistic program, even though if you are practicing as an orthopedic practitioner or a
Exactly.
neurological practitioner, we as a clinician see the patient in total. And that is why at the start of the session, when I said that it is the complete thing a brain should know to see. Otherwise, once you are unaware about a lot of things, you miss out so many things which might benefit to your patient. Or rather, as rightly said in your session, it should not be a disservice to the patient. So thank you so much for such a wonderful session. And thank you so much, IAP India, respected Heta ma'am, for arranging and organizing and helping us doing this session so smoothly. Thank you so much, our respected Gujarat head, Dr. Jaspreet ma'am, and our national head, Dr. Ruchi ma'am, for allowing this wonderful platform through Women's Health and making our clinical practice, uplifting our profession to a higher limit. Thank you so much, ma'am.
Thank you. Thank you for having me. It was such a pleasure. And I would also, again, like to show my gratitude towards the Indian Association of Physical Therapy, the women's branch. Thank you for having